Hey, and welcome to the lecture. Before we jump into the learning, just a quick reminder to check out the workbooks available on modernoptician.com through the Ultimate Apprentice Optician Study Guide or available on Amazon worldwide. It's the best way to accompany this lecture so that you can fill in the blanks, label the diagrams, do everything all concurrently, and elevate your training to the next level. All the links to the workbooks and the website are all in the description down below, so make sure to check it out. Other than that, enjoy today's lesson.
All right, so this is going to be the last lecture on pathology. And we've done quite a bit of pathology. And I think it's important, right, for the obvious reasons that we need to understand what we're looking at and be able to recognize when things are not normal. And for the most part, we've talked about it. And we haven't looked at a lot of images, with the exception of some for the cornea and stuff like that. It's very common in opticianry courses, especially contact lens courses, to just have like slideshows of pathology of what we recognize. And I don't love that because, first of all, the images are not always indicative of what you're going to see at different stages of these diseases. Usually it's like end stage, like really, really bad. And that's not always what you're going to see. And I don't find that it contributes a lot to learning. But nonetheless, I thought I'd do a quick one like this because there is something to be said about being able to recognize things. And it does like encourage discussion, right? So that's why I'm looking at this as this is going to encourage discussion. And we're just going to like kind of zip through it and that'll be it because we as opticians at this juncture here, it's not about being pathology experts, it's about understanding that pathology has a negative impact on vision. And that's what's most important, right? When we get into the contact lens portion, we're going to talk more in a different realm where it's going to be whether or not these diseases affect contact lens wear and whether or not we should be fitting a contact lens when that person is suffering from these diseases, which is a different context. But for this moment, I just want to go over the ability to recognize certain things and maybe have a little bit of discussion if I find it appropriate. All right. So let's go through this. There's going to be a lot. And we're going to try to just kind of hammer through these, right? All right, so first one, notice that this is staining of the cornea. So this is obviously a corneal issue. And this is actually acanthamoeba keratitis. So what's actually the most important aspect here, as I pull out my highlighter, is not that it's acanthamoeba, it's that it's keratitis. So acanthamoeba is the microorganism that is actually causing this keratitis. And it just so happens that certain bacteria and different microorganisms will have distinct types of effect on the cornea. Just so you know, acanthamoeba keratitis is extremely serious. So acanthamoeba is actually something that's found in like stagnant water. So sometimes people who go swimming with their contact lenses can introduce this bacteria, and the bacteria lives behind the contact lens and then infiltrates itself into the cornea, and it's bad news. So anyways, the main thing I want you to realize is that this is definitely keratitis, inflammation of the cornea, and keratitis could come from a number of different things. This just so happens to be the most serious one, which is acanthamoeba. Here we have a image of, it's mostly, I'm going to just get the pen out so that we could see a little bit better. Sorry, the pen tool. Maybe we won't get the pen out because it's giving me a hard time here. There we go. We'll get the pen out with like the, let's go green. All right, so it's mostly looking at this section of the slit lamp beam. And you can see it's kind of hazy and stuff, right? So this is corneal edema. Now, corneal edema, again, is the swelling of the tissue. The tissue is supposed to be completely clear, and when it's not completely clear, you're going to get that haziness. And we already talked about corneal edema. There's lots of different causes for it. However, all we need to know is that corneal edema is no good. So notice here, all the main thing that we're focusing on in this particular image is all these crusties on the eyelids. And we talked about this briefly. This is blepharitis. This is the inflammation of the eyelid. You're going to get all this kind of redness and pink kind of area around the lids, and you get all this discharge and flakiness. And blepharitis is no fun. Basically, the eyelid is inflamed, and the person is not having a good time. This, is an interesting thing. You see how the iris, usually it's a perfect hole, and now it's kind of like a weird keyhole iris. This is a coloboma, which just basically means it's a defect in the iris. This is hereditary, or not hereditary, but genetic. Sorry, this is just at birth. It's congenital is the word I'm looking for. My apologies. Just things didn't develop right. and it just kind of a small little defect. Now, this can have a negative effect on vision because the iris is no longer controlling light entering the eye appropriately. So sometimes there could be surgical intervention. It all depends on how badly the visual acuity is being affected by this. Oh, we talked about this. So notice how the lower lid is taking the shape of this cone-like cornea. This is Munson's sign secondary to keratoconus, right? We talked about it. It's a very common finding in people who have advanced keratoconus, where, well, the cornea is cone-like, and then the lid will actually take that shape when they do a down gaze. Look at this. Obviously, all these scratches or all this kind of messed up stuff on the cornea on the surface. Now, notice that this doesn't look inflamed. And also, it doesn't look like an abrasion where things are stained. It's just like scarring all over the place. So this very much could have been called corneal scarring, but it is scarring secondary to corneal dystrophy, meaning the epithelium in the corneal layer is really not in good shape. And there could be a number of reasons from genetic to improper contact lens wear to surgical interventions that can cause corneal dystrophies. And that's very much a general term that covers all sorts of different, like map dot dystrophy, like fingerprint dystrophy, like ABMD. These are all different dystrophies that affect the matrix of the cornea. This one's very common. You're going to see this lots and lots in the elderly. It's this white rim that we see around here. This is deposits of calcium and cholesterol and different things. We call this arcus senilis, and it's completely benign. It really has no negative impact on vision, on the health of the eye, or anything like that. It's just a common sign of aging. Okay, so nothing to worry about. You're going to see this all the time. And we've talked about this. This is a major one. This is a doozy. However, remember we talked about there's two different types of like eye pimples that we see often. We have the acute one, which is a external hordulum or a stye. Well, this is a picture of a chalazion, something that's not necessarily red and pussy and purulent. It's a hard cyst, right? So this could have been caused by a blocked gland or duct, or it could have been caused by a stye that was not resolved. Although usually the stye is going to be more here on the margin. This is on the inside, so it's probably more of a gland that is swollen up and hard mass. Here it's harder to see, but it's showing these little kind of dots or like swelling kind of lesions or like bubbles. Okay, so this is actually bullous keratopathy, and it's commonly associated with improper contact lens wear, but it's basically causing almost like ulcers, but more like bubbles, like blisters on the cornea. So if you ever examine a patient, you see blisters or bubbles, it very much could be bullous keratopathy. All right. This one should be pretty self-explanatory. The eye has been fluorescein here. The cornea is all illuminated through the slit lamp, and you see the scratch, right? So that is a corneal abrasion. And actually, this is probably a corneal abrasion due to a foreign body under a contact lens. And when the person blinks, the contact lens moves up and down and scratches. The interesting thing about corneal abrasions is that you can see patterns emerging, right? So the fact that this is going up and down like that, I would suspect that there's probably something stuck underneath a contact lens. Next here, we're looking at the staining on the top superior part of the cornea, right along the margin here, right? So this is actually very indicative of superior epithelial arcuate staining, seal, all right? Another contact lens issue, and it's basically debris and things, or like not debris so much, but it's basically dry spots underneath the contact lens superiorly, and it's due to an improper fitting contact lens, and it can cause more effects in the future if it's not treated. Because if you have dryness that never resolves, then you can end up with epithelial lesions, then you can end up with ulceration, then you can end up with keratitis. See how these things all kind of blend into each other? So it's something that's important during the contact lens exam, for example, that we always look for signs of arcuate staining like that. However, generally speaking, other than contact lens theory, you're not going to be thinking about this necessarily in a dispensary, but it is something that we're definitely going to talk about more in the future when we talk about contact lenses. Another iris problem, so we already talked of the coloboma. This is basically very similar. This is aniridia, where basically the iris is not formed properly at all. Where coloboma is more of a defect, this is like a almost absentee iris. This would result in like a significant issue of vision issues, like uh, borderline blindness, because the eye just can't really control the amount of light entering. And this is just bad news. This is very rare. This is This is genetic. This is, um, man, I keep forgetting the word I'm looking for. Congenital at birth, right? So yeah, bad news. This you'll see relatively often enough. Well, not often enough. It's not unheard of to have it come into the dispensary. This is blood in the anterior chamber. All right. This could be a result from injury, mostly blunt force trauma. All right, hyphema. It could also be from surgery and things like that. But blood in an anterior chamber is bad news. It means something on the inside has been injured, right? So if you see a hyphema, you have to refer because we don't know where that blood's coming from, but it's usually not from somewhere good, right? So hyphema, know that one. This is We're looking at this little thing here on the cornea. This is an embedded foreign body, probably a piece of steel, right? From grinding or things like that. That needs to be removed because if it's not removed, you could end up with some significant scarring that will never go away. You could also end up with some significant infection if the thing that's embedded in there was dirty, which it almost always is. So it definitely needs to be referred and needs to be removed. The sooner you do it, the better, because the corneal epithelium heals very fast and it could be harder and harder to get out. This is seen all the time, and we're gonna use a general term for this, and this is corneal staining. So this I would classify as SPK, basically. So superior punctal keratitis. So basically, anything that stains like this means that there are issues with the corneal epithelium here. Things are inflamed. Okay, so basically, there's a stippling on here, and the dye from the fluorescein has stuck on it. Means that there's something wrong with the surface of the cornea. All right. Well, there you go. This is a good one. This patient probably has some kind of systemic problem. Could be Graves' disease, could be hyperthyroidism, which is very closely linked to Graves' disease. This is called exophthalmos. The eye is being pushed out. There's other causes, there could be cellulitis causes, there could be different things. There could be swelling in behind the eye of the adnexa and the muscles and the fat tissue is pushing forward. There's a number of things that can be happening here. However, the main thing is that we know is that the eye is protruding outwards. This is bad news because the eyelids won't actually cover the the eye and the cornea properly. This will lead to dryness. It could lead to erosion. It could lead to a lot of things. Exophthalmos is not good news. This is another common one, and it's marked primarily by the face lesions, and this is a very advanced case. However, this is herpes zoster. This is shingles, right? I'm going to write this down. Shingles. Many people are prone to shingles. This is a viral infection. However, it remains dormant in a lot of people's bodies and can come out when it's in stressful situations and things like that. Herpes zoster or shingles is extremely dangerous when it gets in the face and the eye. This can lead to blindness, to severe corneal infection, and yeah, really, really bad news, right? So if people are having signs of shingles, learn the signs of shingles, like the lesions on the face and the nerve pain in the face or anywhere, they need to be treated and referred immediately. 48 hours. 48 hours before damage is irreversible in a lot of cases. So anyways, I talk about how we're often first line. If you have someone coming in with shingles issues, refer them straight to emerge. They need to be treated immediately. Uh, well, pretty obvious here. Some issue here with the eyelid, right? So this is the eyelid basically curving away from the face. This is called an ectropion. No good for the cornea, no good for anything because, well, tears are spilling out and the cornea and the eye is not being protected in that area. This has to be repaired surgically. But people who have issues like this are going to have severe conjunctival and corneal dryness and will not be comfortable. So if you see anything like that, it needs to be referred. Well, we're looking right here in the center. So this is a corneal scar, secondary to who knows what, probably an ulcer given the size of it. And it's all white and opacified. Be pretty hard to see through the pupil here with where that scar is. That scar definitely is having visual implications. All right. So there's a couple different ways that this could be solved. One of the most common ways, as long as the person doesn't have any kind of healing issues, um, a laser could be used. It's something called PTK, so phototherapeutic keratoconus keratoplasty, yep. So basically, a laser can be used to burn all this away and get a new healed, clear version of the cornea. Anyways, doesn't really matter how they treat it. However, the number one thing is that this is visually significant. If you have a scar like that in front of the pupil, it will be noticed. So, not similarly, but opposite of what we just looked at with the ectropion, this is the eyelid curving inwards and the eye being, the eyelashes basically being absorbed into the eye. This is called an an entropion. Sorry, we already talked about ectropion. And this is even more of a concern because now every time the person blinks up and down, these eyelids are rubbing on the inside, and so the eyelashes, sorry, and it's no good. Very uncomfortable, very not nice to look at, very unsightly. Something that also has to be repaired surgically. This is again a picture of the cornea, and you can see staining here with fluorescein. These little scars are essentially, these are more ulcers because they're live and they're active. Scars are more when it's done. These are very indicative, and it's a very, very common, we call this a dendritic ulcer because it almost has like little feet and little like arms. It is herpes simplex. So herpes zoster is, the shingles virus. Herpes simplex is more of like the cold sore virus, right? But it is also something that could be transmitted sexually, and different things. We know how STDs can sometimes have effects on different tissue. This is what it looks like in the eye. This is something that also has to be treated very quickly because it will leave significant scarring and only get worse. Well, look at this one. This is a lot of red, right? So it's very easy to be distracted by this red. But that's not what we're looking at, okay? This is what we're looking at right here on the cornea. See that ball right there? That is a corneal ulcer. And it is so significant and inflamed that we get severe injection all the way around. So whenever there's an ulcer like this and it's active, this can have a negative effect on the whole eye as itself, and it can inflame the entire thing. So very important to recognize that. But again, the main thing we're looking at is that blister on the cornea. That is a corneal ulcer. It could be due to contact lens wear. It could be used to dry spot that just got worse. Corneal ulcers are usually secondary to some kind of problem, whether it be mechanical or infection or something like that. Things usually develop into an ulcer if not treated appropriately. This is another condition that we look at very commonly in contact lens wear. This is called GPC, or giant papillary conjunctivitis. Remember that the conjunctiva wraps from this part of the eye all the way and lines the eyelids. This is basically the inflammation and infection of the papillary portion, or bulbar. No, papillary. Sorry, bulbar is on the eye. The papillary portion of the conjunctiva, often due to like a intolerance to contact lens solution or some kind of like external factor that will basically inflame that tissue, right? So this is something that we always check for, especially are if people are prone to kind of like discomfort. We always want to roll the eyelid to be able to invert the eyelid to be able to look at to make sure, because this is a sign of contact lens intolerance. Again, corneal issue here. All right. Now these are little dots around the cornea. There's one here, there's one here, there, and there's a lot here and stuff like this. This is very similar to what the ulcer looked like. However, this is more of a corneal erosion because it's widespread. It's not inflamed the way that the ulcer was. However, it's something that can lead to corneal ulcer if not treated. So it basically means small breaks in the corneal epithelium. All right, moving on. Well, this one's common, benign. It's like a defect in the sclera, in the fatty tissue. This is a pinguecula. It can often be due to UV exposure. It's completely benign. You can even fit a contact lens here as long as the interface between the edge of the contact lens doesn't interfere with the pinguecula. However, you'll see this all over the place. Again, very common in southern countries, right, where it's hot and UV exposure is very common. This one's a doozy. This is orbital cellulitis. You're not going to see a lot of this, and this is really, really serious. Usually has other implications, could be secondary to other diseases. It's basically the inflammation of the fat and and skin tissue around the eye, and it's no good, and this definitely has to be treated ASAP, and it's not something that we will be handling. This one at first glance may not seem like much, but if you look here closely, you'll see that there's blood vessels in the cornea that don't belong. Now, the cornea we talked about is supposed to be completely avascular, not supposed to have any blood vessels in that tissue. And there you go, new blood vessels. So we call that neovascularization, growth of new blood vessels. This is a result of something called hypoxia, meaning not enough oxygen has gotten to the tissue, usually because it's been covered by a contact lens. And then the tissue doesn't want to die, so the only way that it can get oxygen is through the blood supply, so it starts growing new blood vessels. Very, very common in contact lens overwear and misuse. And moving on, this is another contact lens related issue, and this is like, again, at first glance, you look at this, like, well, that looks a lot like the ulcer image. And you know why? Because it is an ulcer. It just happens to be the location of the ulcer and in conjunction with what was being done before. This is a contact lens peripheral ulcer. This is very common because if the contact lens isn't fit right, and you could get maybe a little bit of a erosion or something where the contact lens, because if you think about it, the contact lens is over the eye and it moves up and down with the blink. And if it keeps rubbing, eventually it's going to create an ulcer. All right. So this is something that we look at a lot more detail in contact lens theory. This is an interesting one. So this is the cornea, and you can see the iris here and the pupil there. All of this speckling here, okay? This is something that we call pigment dispersion syndrome, and this is basically pigment being kind of expelled from the iris into the anterior chamber, and sometimes it'll spackle like spray paint on the back of the cornea. For the most part, this is actually benign and not something you have to be too concerned about. I've seen this a lot more, people with very dark skin pigment, very dark people of African descent, and with dark irises. It's just the pigment kind of sprays off. For the most part, this isn't a huge deal. We just have to be careful because sometimes there could be a link with this and glaucoma later on, because sometimes all this settled pigment at the bottom of the anterior chamber can lead to trabecular meshwork dysfunction. So just in the back of our minds. Very rare, very rare. This is ocular albinism. Notice how this young man has these white kind of lesions here on his face and blue eyes. That just means it's a pigment issue. And these people typically have very, very poor vision because the pigment, if there's no pigment in the iris, there's no pigment in the choroid, and what we talked about, the choroid needs to be dark and pigmented to be able to control light scatter. A person with ocular albinism is usually blind, or very close to being so. All right. Oh, that's an interesting one. What's this? Well, we're not looking at the cornea, we're looking at the crystalline lens. I mean, if you said cataract, you wouldn't be wrong, but essentially this is an ocular media opacification. There's a lot of different reasons why you could have this. It could be a cataract formation. It could be what we also call PCO, which happens afterwards, after cataract surgery, where the leftover capsule sticks to the implant. It could be a posterior subcapsular cataract. It could be a number of things, but basically meaning the crystalline lens is not clear. So it's kind of more of a general term, right? Here, well, in hyphema, we had blood here, right? But look at this. These are white blood cells. Looks like pus, right? This is a hypopion, and this is an indication of severe infection on the inside of the eye intraocularly. It definitely needs to be referred because something's going on. This had to come from somewhere, and that means the eye is trying to heal itself, and there's bad news in there. So if you see a hypopion, you want to make sure that a doctor assesses this for sure. Look at this mess. So this is neovascularization in the worst possible way, right? So pannus is, oh, sorry, I should probably, pannus is a inflammation of basically everything in front of the cornea and the conjunctiva together, right? So the main, it's very much like keratitis. However, it's basically an immunological response to something bad in the eye. And in this case, this is like really, really severe, right? So you're not likely to see pannus in this degree. Usually, you might end up with some conjunctivitis, right? Well, you got it. And maybe a little bit of keratitis uh, that can be treated. Then you get the pannus where it's like widespread inflammation. So relatively rare, but also sometimes related to contact lens disorders. Almost like a shock, right? The eye is shocked by um, something, whether it's hypoxia like we talked about before or whatever, and this is the response. This one's nice and benign. It's always nice when you see stuff that isn't serious. This is basically a birthmark uh, or a small blemish on the sclera. We call that an nevus. Completely benign. It's not a big deal. People with more pigment often get these. Not a huge deal at all. All right. What's this? Well, this is an interesting one. This is not something natural. This is something man-made or done. These are all sutures. Every single one of these spokes. This is a result of a keratoplasty. This is a corneal transplant. So right now we're seeing it with the sutures in place. Eventually, when the sutures are removed, you will see these white scars all the way around. Not to be mistaken with radial K. So radial K, which is a technique used to try to flatten the cornea and treat um, refractive error, where these spokes would be longer, and there's no sutures involved in radial K, it's actually just scars. But this is just a sign that the cornea has been changed. Reasons for corneal transplant are, dead tissue, things like fused dystrophy, keratoconus also can lead to the need for a corneal transplant. So, anyways, there's a number of reasons. So, if you ever see scars like that or sutures, it means there's a corneal transplant. Interestingly, you can fit a contact lens over top of a corneal transplant. However, you might not want to because it has to be done under extreme observation and following because you don't want to compromise an eye that's already been compromised in the past, right? All right, there's a red eye, right? Well, we talked about this. This is conjunctivitis, the inflammation of the conjunctiva. Now, you could also get scleritis, and episcleritis. Very difficult for us to be able to tell the difference. Um, Ultimately, we know that the conjunctiva is all inflamed and the cornea doesn't look to be. So for that reason, we know that it's probably conjunctivitis or even scleritis. Don't feel bad if you tell the difference. You can't always tell the difference by a picture. Uh, so, we talked about entropion. This entropion usually affects the bottom lid. It can affect the top lid, but this is something a little bit different, but very similar. This is trichiasis, where the eyelid isn't necessarily rolled in as much as in entropion, but the eyelashes are growing the wrong direction. Instead of curving outwards, they're curving towards the eye. All right. Bad news can lead to corneal problems, scratching, epithelial issues, just not a fun time. This again is the staining of a cornea. You can see there's like an inflammation and some neovascularization here. It's all the staining like here, and it's hard to see, but all over the place. These are called, and because of the image, it's very difficult to tell the difference in an image. This isn't on the surface. The difference between this, which is corneal infiltrates, and SPK or any kind of erosions is that this is not on the surface, this is beneath the surface. This is basically cells that are trying to repair something from the inside. This is very much a sign of inflammation and needs to be treated because it can lead to corneal ulcerations from the backside, which usually result in worse ulcers, right? We talked about this. This is totally benign. This is broken blood vessels in the and underneath between the sclera and the conjunctiva and blood traps. This is a subconjunctival hemorrhage. Totally not an issue, but does scare people sometimes and can sometimes cause a little bit of itchiness as it heals. But again, not a huge concern. This is something a little bit interesting. It's not super common in our neck of the woods. However, this is a trachoma. This is a bacterial infection that common in chlamydia infections that can actually cause blindness, and it's really serious. So this is one of the hallmark features of it, is this weird kind of stringiness on the upper eyelid. Not to be mistaken with GPC or giant papillary conjunctivitis, where that has more like bubbles. You probably won't see this, but again, sometimes we show you things that you're not going to see all the time. But this is a significant visual concern or infection in some parts of the world. And look at this thing. I've seen this in action in my time in ophthalmology. This is no fun. This is an enormous ulcer with pus and white blood cells and purulent. This is microbial keratitis. This is what happens when you wash your contact lenses with water. I actually encountered a guy who worked in the wilderness as a logging guy, and he cleaned his contact lenses in the puddle of water because in the wilderness because he got something in his eye and he wanted to clean it out, and this was the result, and he ended up losing his cornea. So this is serious stuff. Definitely need to refer that, and it's bad news. That'd be very uncomfortable. Obviously, visual vision altering, and just overall bad news. Notice how this young child's eye is fully open here and not so open there. So this is a lid issue. This is called ptosis, and it's basically the drooping of an eyelid. Could have eyelid issue, could have a neurological issue, could be a Bell's palsy kind of issue, could be a number of things. So this is a neurological, potentially neurological component, so it definitely has to be assessed, put through a battery of testing to see exactly what is going on here. We've already seen a chalazion. This is the precursor, or a more acute version of it. This is an external hordulum or a stye, basically a pimple along the lid margin. Remember, chalazions usually aren't inflamed. Styes are. And styes are often on the margin. Of course, chalazions could be on the margin too if they're stemming from an untreated stye. However, most of the time your stye is going to be at the lid margin. And here we go, inflamed area here of the conjunctiva and sclera. So we talked about conjunctivitis. Here is scleritis. Can you tell the difference? Not really, right? Very difficult. It needs a really trained eye to tell the difference. As long as you know it's one or the other, you understand that it's not normal, right? The conjunctiva and the sclera are supposed to be, the sclera is supposed to be white and the conjunctiva is supposed to be clear. If it looks like this, it means it's inflamed and it's no good. We already looked at one of these before, but you should be able to name it right away. But of course, this is a pterygium, and it's basically a weird inflammation and growth of the conjunctiva onto the cornea. And what's this one here? This is a skin condition. And you know what's funny? I don't remember which lecture it was. I couldn't remember. Oh, I was talking about blepharitis, and I was saying it's often secondary to this, and now I remember what it is. It's rosacea. But ophthalmic rosacea is a skin and lid condition which will affect this whole area here. It can be very uncomfortable, and it often leads to plus blepharitis, and it's no good, and it's very, very dry eyes. Actually, in some cases, no tears whatsoever. Wow, that was long, right? So I'm into the significance here. I hope that this helped a little bit to understand that there's a whole bunch of different stuff that can happen to the eye, and you don't have to be an expert, but you do have to understand. Just remember that you're not treating, you're just recognizing. And it doesn't even have to be that you're recognizing exactly what it is. Just recognize that it's not normal. You should always have a good understanding of how urgent things are. We talked about subconjunctival hemorrhage, about a nevus, about little things that are not a huge deal. Anything else that you're not sure, well, you're going to have to refer just in case you're wrong, right? So this just comes with experience. Know when to refer. Okay, and it could take you years and years to know when to refer. So at the beginning, you might refer more often. You just don't want to be in a situation where you're not referring when you should have been. So maybe a good rule of thumb is always refer. Just my main thing is understand what normal should look like and recognize when it's not. If you could do that, that's awesome. You don't have to be able to name it. I don't care if you mistake an ectropion for an ectropion, or if you're not sure if it's a hyphema or hypopion. We're not testing. This isn't Jeopardy. This is just being able to recognize that here's what normal should look like, and this ain't normal. So what are we going to do about it, right? Very importantly, we're going to talk about this more. Don't fit contact lenses if you don't know what it is. That's the number one thing in contact lens theory. Don't fit if it isn't normal. Big thing. And of course, we're going to spend an entire course on that. But for the time being, just in case you're already fitting contact lenses and you haven't taken the contact lens course, just make sure that if it ain't normal, don't fit. All right, that should be it. And that is it pretty much for pathology. And we should be good for ocular anatomy as well. All right, so keep going in the course. We'll tell you what to do next. Hope you enjoyed this one.